Thank you very much, respected chairpersons, and thank you to the organizing committee for inviting me for this talk. So today we'll talk about bariatric surgery versus pharmacotherapy, and the focus is going to be on long-term aspects about remission of type 2 diabetes. So we're living in a day and age where we are spoiled by riches. So we have a lot of these options available now, many of them getting increasingly more effective. So we'll do a deeper dive into what the overall remission of type 2 diabetes looks like. These are my financial disclosures that you see on the screen here. Having said this, everything that I'll present today, I have complete editorial control over these slides, and everything is appropriately referenced. Now, when we talk about type 2 diabetes, this whole concept about whether it is remission or whether it is reversal, this becomes very important to understand because a lot of lay media marketing will talk about reversal or cure. So what scientific societies across the world suggest is we shouldn't be using the term reversal because reversal means that it is a finality. Once something is reversed, it cannot come back. It's more like remission because remission suggests that something has gone into hibernation, and if people don't take care of their metabolic parameters or their metabolic health, then that condition can come back. Just like, we talk about cancer going in remission, we don't say that cancer has been reversed. So same concept, the concepts of lifestyle modification and metabolic health need to be focused on. This is especially more important here in India because there's a lot of marketing about diabetes cure. You look at a whole lot of herbal medications that do not have any scientific evidence that suggests that there can be cure, but yet they will market it as an actual cure for diabetes. Now, in Canada, Diabetes Canada last year came out with the diabetes remission chapter, and I'd encourage all of you to take a look at this. There's a QR code on there if you wanted to scan it. It's got some very good tips on how to incorporate diabetes remission in your own clinical practice, whether it's primary care or specialty care. It's very helpful tips. So feel free to look at those papers. But I'll be talking a little bit more about the practical pearls that you and I can incorporate starting when we go back to our clinics on Monday. So let's talk about type 2 diabetes remission and what the relapse of that is concerned. So remission is basically an individual will go off all their anti-hyperglycemic medications for at least 3 months. And at that point of time, if their A1C is between 6 to 6.4%, then it is considered remission to pre-diabetes. If the A1C is less than 6.0%, then it is considered remission to normoglycemia. Now, ADA parameters, A1C is slightly different for pre-diabetes. It's less than 5.7%. So in Canada, we use 6 to 6.4 as pre-diabetes. And then, of course, down the line, if that individual does develop A1C that creeps back up, goes up to 6.5 or high, then it is a relapse of type 2 diabetes. Now, the whole idea is it's very important for us to understand that at the time of diagnosis, there's depleting beta cell function. So the pancreas has lost about 50% of its overall capacity to produce insulin. And having said that, what you'll see is that there's a very finite window where remission is possible. Because as the beta cell mass goes down further, then remission may not be possible after that because by that time it becomes the beta cell function is reduced quite a bit. So the idea is we incorporate this as early as possible after the diagnosis of type 2 diabetes because every year we will lose about 7% of our beta cell mass. So let's find out if you see a patient in your clinic on Monday and that person asks, Dr. Saab, can I go into remission? So what are the likelihood of that person going into remission? So likelihood is higher if that person was ideally diagnosed with type 2 diabetes in the last 6 years. So the earlier the diagnosis, the better, or the more recent, basically. If they're not on many medications and if their A1C is less than 12%, chances of remission are higher. Those that do not need any anti-hyperglycemic agents for cardiovascular or kidney protection. So for instance, if they are on a Flozin and you need that for heart failure protection or for kidney protection, then ideally you can't take them off that medication, right? So they will not meet the technical criteria definition of remission. And those who are able to incorporate a whole bunch of lifestyle modification that is needed for undergoing remission so that they can have weight loss. Now, if you look at the evidence in the literature, the evidence is highest grade for two particular interventions. So one would be low-calorie diets that lead to weight loss, and then the second would be bariatric surgery. So the common theme is weight loss. If you're able to incorporate weight loss, individuals can undergo remission. So that's very important to note. Because what tends to happen is if you look at all the evidence, strongest evidence again with bariatric surgery and low calorie diet along with structured exercise. So if you can incorporate all of these things or at least a combination of these, the chances are very high of going into remission. Now let's look at each of these in more detail. So if you look at low calorie diets, basically the evidence is strongest for 4 landmark studies that had come out in the recent past. So one was the direct trial, then diadem I, U-turn, and look ahead. And all of these had a similar structure. So what you see here is the direct trial, where you have a very low calorie diet introduced between 800 to 850 calories a day with meal replacement. So they were given protein shakes and meal replacements. And the idea was to induce at least a 15-kilogram weight loss. And with that, the idea was if you're able to incorporate that at an early stage of type 2 diabetes, then the chances of remission would be higher. Now, in the look ahead trial, which was again only intensive lifestyle intervention or ILI, the chances of remission you'll see on the screen here. So weight loss at 4 years was 4.7%, and 7.3% of these individuals actually went into remission. So that's a very small number of people that went into remission. And overall, the chances of that happening with just intensive lifestyle intervention are limited unless you incorporate a low calorie diet. At the end of 10 years in the same study, again, the weight loss was only about 6% or so, and the idea of remission was in a very small minority of individuals. So the idea is that this may not have a long-standing effect because most individuals will have some weight regain, and that will lead to relapse of type 2 diabetes. So if you look at all the 4 studies that I mentioned, this is what the study methods looked at. And idea is, again, for low-calorie implementation, followed by gradual reintroduction of food so that it becomes a little bit more sustained. The problem is the biggest out of these studies, the one which has been quoted the most, is the direct study. And if you look at the 5-year data with the direct study, the results are again not very impressive. Only about 13% of that total population that entered the study at the end of 5 years was still in remission. So basically 87% of them had a relapse and then they progressed to continuing to having type 2 diabetes. So that's as far as the lifestyle intervention is concerned. If you look at the concept of remission, this is not new. It's been around for over 100 years or so. What you'll see on the screen here is on the upper panel, we talk about the surgical interventions that have induced remission. And there's a whole lot of different surgeries that have been developed and honed over the last 100 years or so. And on the bottom, we look at pharmacotherapy measures as well as non-surgical methods. So you're looking at either insulin introduced for introducing remission or for lifestyle modification. So let's talk about the concept of using insulin to introduce remission in individuals with type 2 diabetes. So using insulin is a very novel concept as well. So we call this intensive insulin therapy or IIT. The idea is right at the time of diagnosis, that's when the beta cell function is failing. We introduce aggressive basal bolus insulin regimen. We use it only for a little while, giving the beta cells some respite. The idea is that we can then help preserve the beta cells and help with reducing insulin resistance and then introduce this diabetes remission. So if you look at the trials so there's 3 trials here that you'll see on the screen here. Overall, the number of patients that you see is, it varies. So we've got about a dozen patients up to 120 patients in the middle study. Baseline A1C at the time of diagnosis was in the 10 to 11% range there. And these individuals were introduced on insulin therapy, and it was very rapidly, the insulin regimen was very rapidly escalated because they wanted to get to glycemic control within 2 weeks. In fact, some of the studies you get to glycemic control in the first 2 days itself. So very rapid, aggressive escalation of insulin therapy. And once they reached euglycemia, they were kept on insulin for 2 to 3 weeks. And what you'll see is that out of these individuals, when they were kept on it for just 2 to 3 weeks and then taken off the insulin, after that, at the end of 12 to 26 months, between 40 to 70% of these individuals continued to be in remission. So they were not on any medications. They were just given insulin for those 2 weeks. And after that, that remission continued. So this was very reassuring. Then we looked at real world evidence. So most of this is emanating from China because they use this very rapidly and very widely in their country, where at the time of diagnosis, many people are introduced on basal bolus insulin, even if the A1C is not that high. And in this real world study, they looked at 35 days of insulin therapy at the time of diagnosis, and there were people who were followed for a median of 40 years. And we looked at the macrovascular complications, and you'll see that coronary artery disease did not change much between the insulin arm and the non-insulin arm. but the incidence of heart failure as well as strokes was significantly lower in these individuals that were first given insulin for a few days, only about 35 days, and after that they were not on any medication. So that is that legacy effect that continues to go on. Now you might think, why do insulin? Why can't we do oral therapy? So there was a study that looked exactly at that as well. We had 350 patients in this study, divided into three groups. One group got an insulin pump, the second group got basal bolus insulin therapy, and the third group got oral antihyperglycemic agents, which was gliclazide and metformin in this case. And again, at the time of entry, their A1C was between 9 to 10%, and they were introduced into euglycemia between 4 to 10 days. So very rapid escalation of pharmacotherapy to get their blood sugars in the target range. And what was seen was at the end of 1 year, about 50% of people in the insulin group, whether it was insulin pump or the injectable insulin, 50% of these individuals were still in remission after being taken off the insulin. Only about 27% of people in the OAD group were still in remission. If you look at the acute insulin response, so in these bars, the higher the number, the better it is because it is showing the endogenous response of insulin to a carbohydrate load. And obviously, before therapy, the acute insulin response is quite low because these individuals have high degree of hyperglycemia. After therapy, you'll see that all the bars are elevated. But what is very interesting to see is at the end of 1 year, the green bar, which is the OHA group, that active insulin response is much lower compared to the initial insulin group, right? So again, early on, if we introduce insulin only for a few days, we can potentially have ongoing remission. Now let's talk about bariatric surgery. When we look at bariatric surgery, the reason why there is remission is because of two main aspects of bariatric surgery. So one which we all know is the weight loss dependent aspect. So when there is weight loss, there is improvement of insulin sensitivity, there will be reduction of inflammation, A1C will improve. However, there's a lot of weight loss independent mechanism of action as well. And essentially, with bariatric surgery, the incretin pathway is once again revamped. We know that bariatric surgery can potentially lead to alteration of the gut microbiome. It improves the diversity of bile acid, and it also changes the gut-brain signaling. So because of all of these things, independent of the weight loss, people will undergo remission of diabetes, which is why a lot of people right after surgery, they'll start coming off their medications even before the weight loss is manifested because of many of these reasons. So bariatric surgery is probably at the current point of time the most effective and durable treatment of obesity. You all know that there's different types of bariatric surgeries that are being used, that is depending on the patient and the surgeon, where they come to a consensus on what the surgery would be ideal for that particular patient. If you look at all the different types of bariatric surgery and you look at the remission of diabetes, type 2 diabetes, so I'd have you focus on the second row over there, you'll see that depending on the surgery, the resolution rate can be between 30 to 80% remission of type 2 diabetes. So that's very important to note because that is far more than the non-surgical methods. So what you see on the screen here is a meta-analysis of all different studies that have looked at surgery versus oral hypoglycemic agents and looking at what the weight loss is. And clearly, bariatric surgery is far better. All those forest plots are on the left-hand side, indicating more weight loss with bariatric surgery than the older oral hypoglycemic agents. And if you look at the probability of introducing remission of type 2 diabetes, again, all the forest plots are towards the left, indicating it's favoring bariatric surgery. Indeed, if you look at the long-term data as well, at the end of 5 years, the remission of type 2 diabetes with bariatric surgery can be between 80 to 90% with the newer techniques for bariatric surgery versus only about 7% with intensive lifestyle intervention. So bariatric surgery is by far much better than some of these recommendations. Now, having said that, things are probably changing now. We've got now newer medications. We've got GLP-1s and GLP-GIP agents, which will probably be much better than any of the other things that we have been used to. So what you see on the screen here is the results from the SURMOUNT-2 study looking at tirzepatide. And I'll have you focus on that red box here because what we are seeing is after using tirzepatide 10 milligrams or 15 milligrams, about 80% of these individuals are having an A1C less than 6.5%. And almost half of these people, 50% of these people, have an A1C even lower than 5.7%, which is obviously very significant. The next study here is the STEP 2 study, which is looking at the semaglutide 2.4 milligram or Wegovy. And again, you'll see that nearly 2/3 of these individuals, after starting semaglutide 2.4 milligrams after the end of 1 year, will have an A1C that is less than 6.5%. So the idea is that as long as we continue on these medications, there can be ongoing remission. So if I had to just summarize everything, the idea is that diabetes remission can be a distinct possibility as long as we introduce it as early as possible following the diagnosis of diabetes in the appropriate patient. Lifestyle modification is helpful, but it requires ongoing care and ongoing dedication by the patient. Currently, bariatric surgery probably has the best long-term outcomes, but I feel that time is not far away where we probably will be using GLP or GIP-GLP instead of bariatric surgery, or maybe even combination of bariatric surgery and agents for introducing ongoing remission. Thank you so much for the shares.